Well, hello, everyone. It is my pleasure to introduce you to Teresa. And Teresa, can you tell me, how do you say your last name?
Quadras.
Quadras. Teresa Quadras.
There you go.
Lovely. Well, Teresa is a licensed clinical social worker with a 25-year career in healthcare, mostly in palliative care and hospice, which is why I'm so excited to talk to her today. So she currently works part-time as a palliative care social worker and has a part-time psychotherapy practice. And Teresa, I am just thrilled that you are here because I can't tell you how many questions I get from family members about palliative care and hospice and what's the difference between the two and what are things to think about when how do you know when it's time to advocate for those services? What can you expect from those services? All those questions.
Great.
But first, I would love to hear give us a little bit of history about yourself. How did you end up in that line of work, if you don't mind sharing?
Sure. I kind of fell into it. I was just very fortunate. I started out with a home health job, and that kind of transitioned into hospice, and that transitioned into palliative care. But I was so excited to kind of land there because way back in the 80s, a million years ago when I was in college, I took a class called The Social Psychology of Death and Dying. And it was so compelling to me. It was so fascinating how our culture deals with end-of-life issues and how we don't deal with it.
We don't deal with it. Like I said that, yes.
Yeah. And so I was really drawn to that line of work. And then it just kind of played out that way, that I got to spend most of my career talking with people who were facing serious illness or facing the end of their lives, and being in that space with them and holding space for those conversations that don't really happen outside of that context very much. Because like you said, in our culture, it's just not something that people are comfortable with.
Isn't that amazing how, that saying, the only guarantee in life is that you're going to die, right?
Right, right.
Such a part of life is death, and that families almost need a professional to step in to sort of moderate or help have those conversations. And what an important role. And I can imagine the families that you've touched over the years in that position. So yeah. Do you mind, before we jump in too deep, I would love if you could give us kind of an overview about the differences between palliative care and hospice. I get that question all the time. Yeah. And
I would love to, because there are so many misconceptions about both of those things. And so any opportunity I have to educate people about what it means, because people are missing out on what they have to offer because it's scary, right? People don't understand it and they're scared of it. And so it's really a shame that people are putting those things off almost till it's too late. So hospice is specifically for people whose prognosis is likely 6 months or less. It's a Medicare benefit. It's very specific. And it's, the doctor's best guess. I wouldn't be surprised if this person had 6 months left in their lives, and that qualifies them for that Medicare benefit. And that usually goes to where the person is. Sometimes there are inpatient hospices, but often ultimately it's designed to go to where the patient is. So in the home or to a nursing facility or residential care. They have nurses, social workers. There's a pharmacist usually. There's a physician that oversees it, home health aides that can help with bathing, chaplains, volunteers. It's a huge support system, and it's a big support for the patient and the family. And it's appropriate when the goal is to avoid hospitalization and focus on care that supports quality of life and comfort. So for people who are still getting treatment, pursuing treatments, it's not appropriate. But at the point that they're not, for whatever reason, either they choose not to, or the treatments.
So Teresa, we froze up. So I'll have my editor.
Okay.
Fix that. But we totally froze up. I'm trying to remember where you left off. If you, I'm
You want
sorry.
to start over with a question?
Yeah.
Okay.
Is that okay?
Yeah,
Okay.
yeah.
And
Yeah.
so Laura is my editor. Laura, when you
Okay.
listen to this, go ahead and just rewind it back to the beginning of the question. So I'll just re-ask it.
Okay.
So Teresa, I'm wondering if we could start by you just describing to our audience a little bit about the differences between hospice and palliative care, because I think some people are more, my experience is people are more familiar with hospice, but not so much palliative care. But then there's huge confusion on when to access which, and you can't be on both at the same time. And so, yeah, tell us a little bit about what hospice is, what palliative care is, and when it's appropriate. Yeah.
Right. Yeah. I would love to, because it's so important that people understand these, because there's a lot of misinformation and misconception of what they are. And I think people miss out on the services because of that. So hospice is a Medicare benefit. It's very specifically meant for when the prognosis is likely 6 months or less, and when a person is not pursuing life-prolonging treatment, either because they choose not to or because there isn't any that's really going to help. People tend to come onto hospice very, very late. I think the average, this might just be in California, the average length of stay is about 17 days when they're eligible for 6 months of this service. It's nurses, social workers, chaplains, home health aides, a whole team that comes to support the patient and the family to focus on quality of life, managing symptoms, keeping people comfortable, avoiding hospitalization, trying to provide that support in the home or wherever the patient is. And so that's hospice. Palliative care.
Can I ask it? I want to clarify a couple of things. You said so many good things, and I want to just highlight one of the things I heard you say is it's a Medicare benefit.
Yes.
Which means that families do not have to pay for this service.
Right.
Okay. That's huge. I think sometimes people think that they can't afford it, or
yeah.
So it's a free service if they get the referral for it, and it's and then the other thing I heard you say is the hospice team will come to wherever the patient is, or the patient is. So if they're living at home, the hospice team will come to their home. If they're living in a memory care facility, many of our families have folks in memory care or assisted living or nursing homes. So I'm understanding you correctly, right? The hospice team will come wherever they are. That's fantastic.
There are some places, there are some places that have inpatient hospices that you can go to. So that is also a thing. Where I am, that's not the norm. But in some places that is also an option.
I wish there were more. I know in my area in Washington State that it's, I'm not aware of any in our state. There may be, but that's a whole nother topic we could talk about, what inpatient hospice looks like and how they operate. You also mentioned the different team members that families could expect to come out to the home. And so I heard you say nurses, social workers, the doctor, so there'll be a medical professional provider that's overseeing the medications. You mentioned spiritual care or chaplain. Who else? A bath aide, and then volunteers, right? So what are some of the volunteers that that might be available in certain communities that you might see?
It varies a lot, because that's not something that's so well defined. So each hospice probably manages that a little differently. The primary role of the volunteers usually is to provide respite, to come sit with the patient. They don't do hands-on care, but they can come sit with the patient so that the caregiver can take a break, which we know is so important to get those breaks. So that's their main role, but and just social support. But other places might have other things.
I've seen, and I'm sure it depends on where you're at, like you said, who's in the community. I have seen music therapists that will volunteer. They'll come and do live music, like guitar or a harp. And then I've also seen pet therapists come in where they'll bring an animal in and do some just I mean, what better medicine, right? Than
Yeah, yeah.
having an animal that they can stroke or pet or just be near, especially if they've got a history of being around animals. And so I just love, I just thank you for that, because I wanted to highlight some of the unique services that you think hospital is so medical model, right? Hospice. And but in my experience, the hospice team is really skilled at meeting in a person's setting, and they're coming into homes and they're in this sacred period of life, and so to appreciate that many of these professionals have that experience, they've walked that with someone, and so I think that just helps families feel a little better about inviting, these professionals into their private homes.
Yeah, sure. And it provides so much support for the patient and for the families, though. That's what I love about it. Really, they're there for the whole family and working in your own environment to support the care and comfort and quality of life
Love it.
of the patient and the family as they're going through that. And, it comes from the medical model in terms of, there's a physician overseeing it, there's pharmacists, they provide medications, there's certainly that aspect of it. But it's so outside of the medical model in that it really looks at the whole person, the whole family, focused on quality of life instead of treating symptoms, treating illness. I mean, they do treat symptoms, but instead of, what we think of when we go to the doctor. So it's
Right, at
not
all costs, save
right.
someone's life. Yeah,
Exactly.
and that's a great cost for somebody that just wants a comfortable, peaceful move towards their ending. And
And it
oh,
allows people to not have to go to the hospital. They
yeah,
have this is something I didn't mention, they have 24-hour telephone availability. So if
wow,
something comes up in the middle of the night, you don't have to go through the phone tree, through your medical and whatever. You can call and talk to a hospice nurse and they can tell you what to do. And so it really avoids that, like, in the middle of the night panic, what do? I have to call 911 because I need help. And people ending up in the hospital, and people with dementia in the hospital, that can be so distressing and so disorienting. And the chance, the risk for delirium is higher, which exacerbates the confusion. I mean, there's so many ways that just being able to manage the care at home or wherever the person is helps so much. It's tricky with dementia because that 6-month prognosis is a little harder to define,
okay.
and so that is in terms of like when to ask for it. A lot of people feel like they need hospice way before they're eligible when it comes to dementia.
Thank you for bringing that up, because that's the other thing I see a lot of is uh, someone with dementia that's having a significant decline. And as a dementia specialist, we can sort of project or have an idea of how long someone might live or not live. But I have seen over the last few years, it's much harder to get approved or qualified under the hospice benefit based on a dementia diagnosis. And that's been
Mhm.
an area of hardship, I think, for a lot of families when they're trying to advocate for that service. And so what are you seeing, or can you speak to that? Like what tend to be the diagnoses that are getting that approval, or talk to us a little bit about that area.
You can qualify for hospice with a dementia diagnosis, but it has to be pretty advanced.
Okay.
So, for example, if you wanted to look up something specific, there's a FAST score, FAST. You might be familiar with that. You can just Google FAST score. And I think you have to have a FAST score of 7C. So it looks like it looks at the functional level of the person.
Okay.
And you'll see like that's pretty far down the progression of the illness. And so generally if people are mostly bedbound, mostly non-communicative, not smiling, really not engaging, sleeping most of the time, that's the point where hospice becomes appropriate. So those are the types of things they look at: not eating much, losing weight, all of those different kind of functional
That's
aspects.
really helpful. I know our listeners are going to appreciate just knowing about the FAST score, and being able to look at their loved ones and kind of get an idea of where they're at there. So thank
Yeah,
you for that.
yeah. The problem is that the time leading up to that can be really difficult to manage, and medical situations might come up and people might have to go to the hospital. And if people want to focus on quality of life or comfort focused treatment and not go in for curative treatment and all that, it's really hard to manage that care at home when things come up. And so it's just a huge gap in our care system. And it's just such a challenge. And I think everybody recognizes that, and there's no real easy answer. Palliative care can be helpful in those grayer areas.
Grayer areas.
Mhm.
What sticking with hospice, I have a couple more questions, and then I'm really interested in palliative care. So two questions that I have. Well, one is, can you speak to, I know that many of the families that I've worked with, we've been able to get really equipment that's been needed.
Mhm.
And when I say equipment, I'm talking about things like a hospital bed that can raise and lower, or many families have stairs, and so they're bringing their loved one home, but they can't get them upstairs or downstairs, so they'll set up a hospital bed in the living room, or maybe oxygen or certain medications that are going to not prolong life but help with their comfort symptoms.
Mhm.
I think is really important. So is there anything else to that equipment piece that would be important, or for families to know about there?
Well, yeah, just that if hospice orders durable medical equipment for you, it should be covered as part of the benefit, and medications that are, like you said, not life-prolonging medications necessarily, but needed for comfort. Um, and if someone is on hospice and, they fall and break their leg or something, they can still go to the hospital. I think that's something that people worry about, is whether or not they're allowed to go to the hospital. Getting hospital treatment and getting hospice treatment, you can't do both because it's the same benefit. Like Medicare will pay for one or the other, basically. But if you decide there's something you need to go to the hospital for, you can sign off of hospice, but it's meant for people who don't want to go back to the hospital if possible. And if there's something that can't be managed at home, hospice can arrange for you to go to the hospital under hospice, like if your symptoms can't be managed at home, for example.
Yeah.
So there's some leeway with that, but they don't cover that 24-hour care usually. So that's something that families still need to be tending to.
That's a good, I know, I'm glad that you brought that up, because sometimes I have definitely had families over the years that have assumed that, oh, I'm going to get hospice, so I don't need to pay for caregivers now.
Right.
And
They can take care of everything.
yeah, it's not like
Right.
that. Yeah. I'm thinking, so what that would look like then, maybe you could describe sort of an average week, who to expect in the home, what they're doing, and how long they'd be there.
Sure. And again, it's going to vary. It depends a lot on the patient and family's needs. So starts out, it has to be a referral from a physician. And then usually the first visit is done by a nurse, it could be a social worker. And the first visit's pretty long because they do a thorough assessment of the needs. And then there's some paperwork and all of that. And then the nurse case manager, usually the one who's kind of coordinating everything is the nurse. And that person will kind of assess the needs and set up a plan. They might come anywhere from once a week if the patient is pretty stable, to once a day if if there are a lot of symptoms and things are changing quickly.
And then they would stay for, I know all of this is relative to each person's situation, but maybe an hour or so, or
Yeah, 45 minutes or an hour. It depends. Some nurses are seeing 6 or 8 patients in one day. So it depends on, every hospice is going to have its own bandwidth, but they're there to address the medical needs, make sure the patient's comfortable, make sure the family knows how to manage the medications, and it's longer than a doctor's appointment for sure, but they're not going to stay and, do all the hands-on care all day long like that. They're there to make their assessment, do their skilled nursing piece of it, and then move on. So it might be 20 minutes, it might be 45 minutes. If there's a lot going on, they try to be pretty flexible.
Nice.
And then a social worker would come in and do a whole psychosocial assessment, ask a lot of questions. The first week on hospice is a little overwhelming because all these people are coming in and doing their assessments, but then it kind of settles down. And the social worker is there for emotional support, anticipatory grief counseling, helping with planning. And again, that's super flexible, that the social worker will work with a family to develop a plan. And those plans change as the patients and the family's needs change. And then a home health aide who helps with bathing might come in a few times a week, 2 or 3 times a week, so they're not there all the time, every time you need to get cleaned up, but, a few times a week they come in, make sure all the bathing is taken care of. And not every patient needs that, but that's available. And they might be there, again, for an hour. They might change the linens, make sure the patient's all clean and comfortable before they go. Volunteers are usually 4 hours.
Even I mean, those bath aids, what a relief for families, that alone. And that's a little moment of respite for a family member. And what a tender, I'm sure, experience for the patient as well, to have someone taking their time. Also a professional that knows how to do bed baths or
Exactly. And the home health aides and the nurses too can teach the family members how to manage those things more easily. And you're right about just the intimacy of it. I mean, a lot of times we would see our patients would talk with the home health aides and in ways that they weren't comfortable talking with anybody else, just because they're there getting a bath, And so it's a huge, huge comfort and help to have that support.
Great. I thank you so much for talking about. I mean, I think this is just a nice overview of what families can expect if they are accepted onto hospice. And so do you want to tell us a little about palliative care and that looks like? I think this is where, again, the area that most people have questions because it's not as commonly used. Is it because it's newer, do you think? Okay.
Yeah, it is a relatively new medical specialty. And because it's new, it's practiced really different in different medical settings. Some places might not even offer palliative care services. To palliate means to comfort. And palliative medicine is that more comfort-focused medicine. But as a service, it's like hospice in that it's a medical team. It might be provided in the clinic. Some of them do home visits, some of them don't. It might be provided in the hospital. So I've worked in inpatient and outpatient settings and done home visits. So it just depends on how it's set up in your medical system, really. But it's meant to be a transdisciplinary team, just kind of like hospice. Usually with hospice, you'll have a nurse and then you'll have a social worker. In palliative care, they often work together. You might meet with the whole team at once, including a chaplain or a nurse and or a social worker and or a physician. And their job is to assess and address distress, which sounds funny when you say it out loud, regarding any kind of serious illness. So a serious, likely life-limiting illness, really through any point of the disease process. Usually if someone gets a cancer diagnosis, for example, and they're getting treatment and they're likely to be cured, they're not going to see palliative care. So it's those situations where it's likely going to be life-limiting at some point, but it's not specific to the last 6 months of life. It's not even necessarily specifically end-of-life treatment. Okay. So you can meet with this team and say, okay, this is where I am medically. This is what I understand. What should I be expecting going forward? What are the medical decision-making points? What are the treatment options? How do I balance those? And you have a whole team to support you through that decision-making, through looking at the big picture, through making sure, maybe you have a family meeting, making sure the whole family understands what's happening, where are we with this illness, what are the treatment options, what should we expect? And I think the most important thing, well, 2 important things. One is they're also focused on quality of life and comfort, and they can help manage symptoms and those,
you made me think of something. I want to, sorry, I'm interjecting. How when you're on palliative care,
Uh-huh.
but so I know with hospice, you assume the doctor that is under hospice. So you're kind of letting your primary care doctor go and you're working with the hospice doctor. How does palliative care work? Do you still have a primary care physician and they're working together, or are you now under the care of the palliative care doctor?
You know, I don't want to say necessarily one way or the other because I don't know how it plays out in different medical systems necessarily.
Sure. Okay.
My experience with it is that you keep your regular team. We don't replace any services that are already there. And so sometimes it's a one-time consultation. You know, you're not even on palliative care necessarily. You might just consult with the palliative care team.
Okay.
In some places, they can follow you longitudinally, and you would be on palliative care, and they would, follow up with you more long term. But that's really not as common. It's just not. There's not funding for that in a lot of places. So a lot of times it's just a consultation, and they'll work with your primary team. Same thing in the hospital. You still have a primary team addressing your medical situation. The palliative care team would come in and consult.
So it's in addition to your current medical providers. Okay, that's helpful. Yeah, I thought something I wasn't very clear on. I've seen in the hospital setting the palliative team, care team at work, but not as much at home. So that's really helpful.
Yeah, I mean, and sometimes it's just not offered at home. Sometimes they only have it in the hospital setting. So it varies quite a bit. But I think that my biggest message is don't be afraid of it. If somebody offers you a palliative care consultation, say yes. It's all added value. They don't take away anything. People think it means stopping treatments and stopping all my meds. It's not that at all. It is, you can have active treatment and still have a palliative care consultation. So they're there to support you wherever you are in the disease process. And the most useful, most important piece of it, which is something that I can talk about in more depth if you want, is helping with the medical decision making.
Yes, please talk about this. Is huge for caregivers.
Yeah.
Thank you.
And so this whole team of professionals, and you might not meet with the whole team, you might just meet with one of them, but they're trained to kind of to facilitate the conversations of, okay, what's at stake medically? Where am I in this? What's the best case scenario? What's the worst case scenario? What's the most likely scenario? What if I opt for this treatment? What if I don't do that treatment? What is that going to look like? This is what's important to me. How do I take my goals and my priorities and my concept of quality of life and translate that into medical decisions? That's hard. That's so hard to do by yourself. It's so
I love you said that so beautifully. I want to go back and quote you. What I hear you saying is that palliative care consultation or meeting with a team, whether it's once or multiple times, the goal is really to educate the family and the patient, to review the pros and cons of all the decisions that are available. And also what really stuck with me is recognizing that each individual person or family is going to have their own values, their own goals, their own the things that are important to them as individuals. And so I just love what you said, and that is that this team is there to support families in recognizing what is important to them and understanding all the choices that are out there in relation to those values and goals.
Exactly. Yeah. And it does, again, step out of the medical model because, you might spend an hour. I don't want to guarantee you're going to get an hour necessarily. But working in palliative care, I've spent, 90 minutes sometimes with a patient or a family, and more than one time, completely focused on the patient's quality of life and what's important to them. And all the ways that the medical system can and cannot support that. And how do we develop a care plan based on that? That's what it's for.
Love it. Oh, thank you so much. I think this is going to be so helpful for people to understand that. So tell me, what are some ways that you work with caregivers to help them manage that phase in their lives?
So let me,
depending, I guess, on which hat you're wearing, right?
right, exactly. Let me switch our focus a little bit and come back to that, if that's okay.
Sure. Yeah,
Okay.
totally. Yeah.
So
Yeah.
I think from what we were just talking about, then the thing that I think would be most useful to discuss is sort of just what does medical decision making look like for people with dementia?
Perfect. Let's go there. Yes.
So that kind of flows from the palliative care piece of it.
Mhm.
Because this, again, this is so important. I'm so excited actually to have a chance to talk about this. Because with dementia, when someone first gets dementia, you think about it in terms of memory loss usually, right? You don't think about it as a medical situation, a medical diagnosis that's going to progress and need medical decision making down the road. It's more like, how do we deal with this forgetfulness and those things in the beginning? And so by the time medical decision making comes up, when there are medical complications, usually by then the patient no longer has capacity to make their own decisions, right? And then it falls on the family or whoever, and who makes decisions at that point can be a really complicated question. And how they make decisions is another complicated question. So I think the two things that I would love to speak to for caregivers in that situation, one is to plan ahead as much as possible, to not be afraid to talk about these things, because the more you talk about it, the more information you gather, the more you plan ahead, the easier it's going to be in the long run, and the better you can honor the patient's wishes. And it's hard to talk about these things, especially when someone first gets dementia. It's hard to talk about, invasive medical treatment. It's just doesn't seem like it's part of the equation.
Right. Yeah.
So in terms of planning,
often families are still individuals, and
Mhm.
families are still reeling with that
Exactly.
diagnosis and not understanding what that means. Some people aren't ready to accept and dive deep into understanding that. So I know there are some helpful tools out there that might be, can you speak to that?
Yeah.
Some sort of guidance, whether it's meeting individually with someone like yourself, or going online and finding a resource, or having something, printed document that can help walk them through that.
Absolutely, yes. I mean, it's kind of complicated, so I'll try to simplify it as much as I can. It depends on where you are in the process. So if someone has just been diagnosed with dementia and maybe they just have some forgetfulness, they still have capacity to make some medical decisions. And if they haven't already, they should write an advanced healthcare directive.
Right.
And that includes a durable power of attorney for healthcare, which legally appoints a decision maker for if and when that person can no longer make medical decisions. And that's so important.
Yep.
And it can also have the advanced directive piece, like the living will piece, that talks about their wishes. There's a great one that's just that part, just talking about their wishes specifically for dementia. And it's at it's dementia-directive.org, I think.
Okay. We'll look it up. I'll make sure I put it in the show notes.
Yes, and it's beautiful. And there are other ones too, but this is one is specific to dementia, and it's not a legal document. It's just a way to document what your medical wishes would be in the context of dementia. So advanced healthcare directives is the first step, but somebody has to have capacity to execute that. If somebody has a trust, they've probably already done one and there's one in the trust. If not, you can get it online. You can just Google advanced directive. They're kind of different ones in different states, or you can go to your doctor or your healthcare providers and get one. If you meet with palliative care, they'll look at all of this stuff with you. So that's one piece. Some medical settings have specific facilitators who can talk you through advanced care planning. I have a lot of information about it in my blogs on my website. It's another place you can start, and a lot of links to resources.
Right.
So that's the first thing. If someone has capacity to make decisions, to designate an agent, to document their wishes, you can do that in an advanced directive. The other document that's important is a POLST form. And I think actually one of your other guests mentioned this. I remember hearing
Yeah, we've talked about that. Yeah.
Yeah.
Let me ask a question about that. I'm curious, again, because we're in our separate areas all over the country. In your state, is a POLST form typically on a green piece of paper? Is it on a colored piece of paper? Do
Oh, it's
they?
just pink. It's hot pink.
Oh, it's pink. Okay.
Yeah.
It's lime green. It must be the Seahawks. It must be the Seahawks green.
I don't know why I was just pink then, but yeah.
So funny, yeah. And then the other thing that I know about the POLST forms, Physician's Orders of Life-Sustaining Treatment, is, and tell me if it's this way in California, is the first responders are always know if they respond to a 911 call, they always look at the refrigerator to see if it's there. So, okay, same for California. That's fantastic. Okay.
Yeah. And that's really what it's meant for. It's to document how aggressive the person would want medical treatment to be in an emergency, right? And the thing to think about with this is that when you're talking about CPR, for example, it's people have really, really not appropriate education for what the reality of that is, I guess. Like the things we think about, what we see on TV, for example, is not what it's like. And so I really recommend talking to, like if the patient themselves, or even for the patient, talking to the doctors and saying, you know, what should we expect from the course of this illness? What are the medical decision points that are going to come up for us? You know, what are the complications we might anticipate? Because when you think about dementia, you don't think about the medical things that can come up. So educate yourself about that, and then talk to your doctors. Well, if my heart stopped and I stopped breathing, what would the likely outcome of CPR be for me? You know, and that it's different depending on where you are in your life, but it's not usually very successful. And if it is, people usually end up on life support with brain damage. And, you know, getting CPR doesn't normally take you back to the quality of life that you have now, you know. And so that's just one of the pieces of the POLST form. It's the most important part is the CPR question, but they often have other questions like, would you want to be on a ventilator, antibiotics? Do you want to go back to the hospital? You know, other questions like that.
Artificial nutrition.
Yep. Yes, which is a big one for dementia. That's a whole other talk right there. There's so much to that. So I think the question is, you know, what's the quality of life like now? Any medical decision. What's the quality of life like now? What is the medical intervention that we're talking about? What does that entail? And what's the quality of life likely to be like afterwards? Right? Those are the three things to look at.
That's so helpful. I really love the way that you just broke that up for people to be thinking about.
And, you know, it's so hard because in a medical emergency, you know, people will say, you'll get to the emergency room and they'll say, do you want us to do everything? And you're like, yeah.
Right.
You know, there's not a lot of conversation around that.
Yeah.
So it takes a lot of education and conversation in advance to really be prepared for that kind of decision making.
You know, you bring up such a good point, and that is, you know, most people like to think that they're planning in advance and they're prepared for anything that might come their way. And we know, you know, as human beings living life, that you can be often as prepared as you can be, and something else may come up and hit you. However, everything that you spoke to across the board, whether that's getting, you know, your power of attorney document in place or having the conversation about someone's wishes, those things, when we're talking about end of life and when we're talking about dementia, they're inevitable, that you will need those things. And so I love that we're having this conversation.
Yeah, it's so important, and it's such a neglected topic. So I'm really glad we're having this conversation too. I get very excited about talking, even though it's, you know, it's a hard thing to discuss, but I mean, I've just seen what happens when people plan and when they educate, when they think about it and talk about it, and when they don't. And it's a vast difference in how things go. And I guess, can I just say one more thing about decision making in the context of dementia that I think is so important? This is something that I use in palliative care all the time. It's so hard as a family member to make a decision for somebody else. It's so hard. And we're so invested in, you know, all the work we've done to get them as far as they are and wanting them to be around and all of these things. And so actually making decisions about medical treatment is just fraught with just these layers of complications and emotions and our own investment in it. And what I find to be most helpful is think about the person before they had dementia. think about who they were and what was important to them, and imagine that person, if that person could be in the room right now, looking at the medical situation, looking at themselves in the hospital bed or wherever they are, right? If that person from 10 years ago, whenever, could be part of this conversation, what would they be hoping for? What would they be afraid of? What would be most important to them? And that really, really, really helps, because then you're really just speaking for them.
Mm.
You're not making a decision on their behalf. It's like you're channeling them.
Yes, that and that I can see that can take some of the I don't want to say burden, but stress off of,
Mhm.
the decision being yours as the decision maker, and kind of trusting that. I love what you said, the idea of kind of channeling that person's past self, and the decisions that they would have made if they were able to do that, or
Yeah.
able to see the situation they were in now. Can you talk a little bit about supporting the caregiver? The
Mhm.
talk a little bit more about that.
Yeah.
What
Yeah.
are some suggestions, that you might have for self-care, or paying attention to what the caregiver is actually going through during this period of time?
Yeah. Yeah. There's so many. There's so many
Yeah,
ways to
we
look at
could be on for hours.
I know, it's true. I think the one thing that most comes to mind, and this is in these situations and in general, when I worked in hospice, I worked in hospice for 12 years. And the saddest part of working in hospice is not people dying, because we all die and we know our patients on hospice are going to die, and it's sad, and it's hard on the families. The saddest part was watching what they did with their time. And so in a dementia case, it's more the caregiver that I would be speaking to than the patient. But I'm thinking about my patient's experience, when a patient is saying, this can't be happening to me. This isn't the way things are supposed to go. I don't want to be in this situation. And caregivers might do the same thing. I've seen so many, and actually, yeah, caregivers really go through that process too. I don't want this to be happening, right? So much of their energy is spent on wishing it wasn't happening and kind of railing against the reality of it. And when people are so focused on, wait, this is not how it's supposed to go. This is not the way we planned it. This is not what I want to be dealing with right now. And so much of the energy is focused on that. There's so much opportunity that's missed, right? Because in these, I talked about in my career, I've spent a lot of time talking with people at the end of life. There's so much beauty in those conversations. There's so much opportunity for connection and grace and wisdom and resolution, all kinds of stuff. But when you're just fighting the reality of the situation, you just miss those opportunities, and not just at end of life. I mean, in general, in caregiving in general, I think there are tons of opportunities for connection and satisfaction and laughter and, all of those things. And so I think what I've been thinking about lately is this idea of radical acceptance. And I think this is a really neat notion for caregivers to consider. Like, what if I just radically accept this is my life right now? Yes, my loved one has dementia. Yes, I can't do what I want to do because I'm caregiving. It's not what I would have chosen, but here I am. I'm just going to accept that this is the situation. And it just shifts so much of your experience. So many things that we don't have control over in these situations. You don't have control over the progression of dementia. There are things you can do to, help a little bit here or there maybe, but kind of out of our control. So what is under your control? And really where we put our attention, what we focus on, what we engage with, what mindset we bring to the situation, where we look for opportunities for growth. Those are the things that we have control over.
Have you
So,
heard the saying, where attention goes, energy flows?
right,
Yeah.
yes, right.
And
It's
how,
a practice, right? It's a practice to kind of
it is,
shift your focus that way. Yeah. And the same thing, if you're making medical decisions, you can spend a lot of time saying, well, gosh, I wish this person didn't have pneumonia and I didn't have to make this decision, right? But that doesn't help you make the decision, right? So I think that goes with decision making. You have to be really realistic and accept this is where we are right now. And these are the possible outcomes either way. And that's the only way you can make a good decision for somebody, is by really allowing yourself to be in that space.
I imagine that you have witnessed, over the years that you've been doing this work, so many situations and experiences where people really wrestle with that acceptance. And yeah, if this is kind of a trick question, because I know it's unique, but I want to ask it anyway. And that is, have you seen, I don't know if you can even answer it, but what would you say might be the most helpful for a caregiver that is really struggling with that acceptance? That just, maybe cognitively, consciously, they may know, I just need to be okay with this. I just need to accept this and move on. But there's something inside that is just resistant to that. What would you say to somebody that is going through that?
Boy, there's so many layers to that. A couple things. One, it's okay to see a therapist. I mean, this is really, really hard. This is really hard. And so, actually talking to a therapist or a counselor might be able to help kind of work through those layers. So that's one piece of it. Hospice and palliative care support both are really great at supporting people through those. So I think asking for help with it is one piece of it. It's a lot for one person to reckon with.
And I hear you saying too, I hear you saying too that creating the space to, because what I see sometimes is not all the time by any means, but sometimes people busy themselves, their minds and their bodies, with caregiving tasks. And then it almost turns into kind of a protective mechanism of not having to look at those things, right? Having to explore that.
Yes, right.
And so,
see that a lot. Yeah. And that's one way of coping, right? And some people need to cope that way, and that's okay if that's what gets you through. And there's this whole other level of coping, shall we say, that you're missing if you're focused just on the tasks. And there's so many tasks, it's so hard not to be focused on the tasks.
Right. Yeah, that's kind of a luxury sometimes to be able to not have to deal with the day-to-day.
Yeah, so creating that space, I think, like you said, is the key to it. I can give you one kind of format that I use, if that would be helpful. I don't want to take too much time, so I'll just go through it quickly. And it's on my website too. You can.
Yeah, I will definitely list your website in the show notes so that people can find that.
I teach a class called Living with Intention, and I developed this model in the context of that class. And I think that this could be really useful for what you are asking about. And I call it the ARC model. It's just the acronym, ARC. I'm calling it right now the ARC Model of Equanimity, because that just kind of seems to sum it up. But the A for ARC is awareness and attention. And I'll go through this in a little bit more detail. The R is a reframe, and the C is a compassionate choice. A realistic reframe, I should say, and a compassionate choice. So first, awareness and attention, just taking that, creating that space, like giving yourself your own attention, just look inward, even for a moment. You can practice this in just a few moments, but just stop and pay attention. Okay, what's going through my mind? Where do I feel it in my body? What's that bringing up? What needs my attention right now? What's coming into my awareness? Just give yourself that space. And once you kind of shift into that caring observer mode, just by paying attention, things start to settle just a little bit because you're not in it. You're kind of observing it. So attention and awareness. And then the reframe is a release and replace. So release any comparison, or judgment. So comparison, like, this is not the way my life was supposed to be, comparing what's happening to the way you expected it to happen, or judgment. This is too hard for me, or I'm not doing enough as a caregiver, whatever that judgment is. Just see if you can just let it go, even for a minute, and replace it with acceptance and curiosity. Okay, I may not love this, but this is where I am. Okay, let me be curious about it. What are the opportunities in this moment? What are the growth edges? What are the resources I have that I need to bring to bear to this? Whatever, just be curious about what the situation has to offer. And from there, you can move into a compassionate choice, whatever that might be, and move forward. And that sounds like a lot. You can do that in 30
Teresa,
seconds.
that is so beautiful. I cannot believe how much you just summed up with your ARC model. I feel like we need a whole nother show that we can you can walk us through. I'm definitely encourage our listeners to go check out your website. And so is there a place on your website that, is it a clear link that they can learn more about your Living with Intention class and the ARC model information?
Sure, yeah. So my website is www.teresaquadras.com, just my name, TeresaQuadras. Sorry, I said that really fast, but we're running out of time. So
I'll put it in the notes.
And so if you just scroll down, there's things, just about my practice on there, about caregiving. At the bottom of that is the Living with Intention class. And then there's a blog page. You can navigate to the blog page that has stuff about caregiving, it has stuff about advanced care planning, and it has stuff about the ARC model, and more to come.
This is a beautiful gift. I mean, really, I want to thank you because you're sharing this freely, and this is information that can absolutely be life-changing. I mean, it like you said, it sounds so simple, and you can do it in a moment, but these are where the shifts are, right? This is where, when we talk about reframing, I mean, those are these magical moments that can be life-changing in just a split second. So thank you really for sharing that.
You're welcome. My pleasure. Thanks for the opportunity.
Yeah. Is there anything else that we haven't touched on that you think would be really important for listeners to know about, or that you want to share?
There's just one other thing that comes to mind, and I'll just cover it briefly because I can't even remember where I found this. I did not make this up, but I remember reading somewhere that the 4 elements that make caregivers most successful in providing great care and also managing for themselves, getting through it, are mastery. So like a feeling of competence, really learning about what you're doing and a sense of mastery. Coping strategies, like how do you cope just right in the moment, like using the ARC model, for example, things like that. Social support and stress reduction. So I'm just going to put that out there that, that's something that we can stop and think about. Oh, okay, well, how am I doing with each of those? Is there one of those that I need to develop more?
Mastery, coping strategies, social support, and stress reduction.
Right. And if anyone runs across that article, let me know, because I don't know what the source is. I would love to attribute that to somebody, but I'm going to pass it on anyway because I think it's useful.
Fantastic. Oh, Teresa, thank you so much. I mean, this was a fantastic, you are a fantastic source of information, and just so grateful that you joined us today to share this information with our listeners.
Yeah, you're so welcome. It was my pleasure.
Great.